We all know that the rotator cuff, they tear at the footprint and they get retracted, basically an avulsion from the GT. But we had an experience of treating a case of at the musculotendinous junction, which is quite rare. Can I have the next slide, please? So we all know that these rotator cuff tears at the musculotendinous junction, they are quite rare. In fact, the search of literature showed that the reported cases are less than 10. The etiology could be acute when it is secondary to a trauma. This usually happens in a young patient. Or it could be a chronic trauma because of the subacromial impingement. And the next most likely cause is a failure of a previous rotator cuff where the knots are not placed correctly or not in the correct place. So they are challenging to treat. So what are the challenges in treatment of a musculotendinous cuff repair is that there is a very short medial tendon stump. Then there is a susceptibility of sutures to tear because the medial tissue is quite degenerate, not of good quality. There is difficulty in restoring the proper length of the length tendon relationship, and there is lack of sufficient clinical outcome data to guide decision making in such cases. So when you are dealing with such a patient, the important thing to consider before considering a repair is how chronic they are, what is the degree of retraction, what is the amount of fatty change, what is the tissue quality which remains on the medial side, and what is the length of the remnant tendon, and the quality of the bone and the acromial pathology. So all these factors have to be considered before you take up the patient. So these tears, Dr. Millett has proposed a very good classification, and it is primary if it is because of trauma, and it is type 2, it is secondary to an earlier rotator cuff failure. And then the second classification is by the tear pattern, where there is a short but adequate medial tendon, type B where there is a deficient medial tendon with healthy muscle, and type C where there is a deficient medial tendon with retracted and atrophied muscle. So this classification helps in planning of the treatment of such cases. So this is the type A tear where there is a short but adequate medial tendon, and we do a bridging type of repair in such cases. Then there is a type B where there is deficient medial tendon but the muscle is healthy. One can do a bridging repair with graft augmentation. And the type C where there is a deficient medial tendon with again retracted and atrophied muscle, where we either do an SCR or a transfer or a reverse shoulder depending on the age and the other factors. So this is a patient who presented to us 1 year back with a history of road traffic accident in which he fell on his outstretched hands. He had pain in his shoulder, difficulty in lifting the arm, and painful restriction of movement. All his tests for supraspinatus were positive, plus he had an apprehension test also positive. So this is the MRI. You can see a supraspinatus tear at the musculotendinous junction, but you can also appreciate that medial to that there is some amount of healthy tendon left. And since the patient had come to us acutely, plus he had also had a labral tear with a sort of glad type of lesion. So can I have the conservative with pain medication and physiotherapy?
We can vote on this as well. What would be the management
Injection
line?
of PRP or stem cell, subacromial decompression and debridement alone, or a rotator cuff repair.
Right.
So everybody will do rotator cuff repair, obviously. The type of repair was tendon to tendon.
Plus, please go ahead, sir.
Can you have the next, please?
Next slide.
So the review of literature, we went through the literature, and there are very isolated cases of incomplete tear which was treated conservatively, one instance. Another instance, again one tear of supraspinatus which was treated conservatively, but evidence was not very convincing. There was another technique described by Bancha where only lateral row anchors are used, and he proposed a tendon to tendon healing in such cases. But the most comprehensive review and on this topic has been by Dr. Peter Millett, who the three types of tears which I described, whether there is sufficient tendon present or not, what is the quality of the muscle which decides the three types of treatment. So this is the review of literature. Can we have some discussion, Dr. Ashish? Any experience with such cases, musculotendinous junction?
Again, extremely rare, but when they do occur, it's difficult to comment on the quality of the muscle on the MRI. So classification is very useful.
Has there been any your experience in any
Yes, we've done a few, and we've done both the lateral row repair directly and also a muscle to tendon if it has a good bite, younger patient. We've done both those options.
Then sure.
So again, rare, but we've done these, and when we get the tendon to tendon, I do a tendon to tendon repair, but I'm going to take the fascia lata and keep that as an augment on top, but not a triple, just a single layer, and on the medial side sutures, it's sutured, and then that is just pushed down onto your lateral row. Okay. So it acts like an augment on the top, so you've got some tissue besides the repaired part. Okay. And in some of the type 2 re-tears, when you get them, where it's just muscle tissue, I think those are the ones where no sort of repair is going to work. Those are the ones where we've done an SCR.
Right. So what are the predisposing factors according to you, Dinshaw? I mean, why do you think in a primary situation one gets a Cho type 2 tear pattern in a primary situation?
Why does it tear there?
Yeah.
As against the tendon?
Yeah.
So I think your tendon, so the ones we've seen are slightly younger patients. So the younger patients tend to have these muscle tendon junction tears as against the older patients who have degenerate tendons. I think the tendon itself is quite healthy. Therefore, if you had a tendon or a tendon junction tear, we opt to do a repair because the tendon is not that, it's the quality of the tendon is not that bad in the primary ones at least. So now, some of them, I think, have to be differentiated from the L tears. That's different because you get a tear which is at the tendon and then you've got the L which goes into the muscle tendon junction. And those just need to be treated like an L tear and not necessarily a muscle tendon junction tear.
Thank you.
And some of these where they have calcified tissues.
Yes, that was my point.
Which changes the tensile strength, and that's where they give. Yes. And that happens at the junction commonly.
Yeah.
Anyone else who has some experience of dealing with such musculotendinous junction? So they are obviously very rare. So this is what we saw, and this is what we did. This is an intra-articular view, and we debrided the subacromial space. There was a lot of synovitis. We did a thorough subacromial decompression, prepared the bone bed, and then tried to see what is the reducibility of the tears. That is the most important factor. And we were very lucky that this tendon we were able to bring it back to the bony bed. So we just treated it just like a normal type of rotator cuff tear with the two medial row anchors. Contained both these medial row anchors contained a fiber tape and a fiber wire, and we took the bite and the normal type of repair, which we retrieved these sutures posteriorly as well as anteriorly. So there was some amount of tendon, and the most important thing was this was a young patient. It was a patient came to us acutely, and the repairability, the reducibility of the tendon was there to the footprint, which made our job quite easy. So this was a rare, but of course we could handle it with the normal techniques of rotator cuff repair.
So did you add tendon to tendon sutures as well?
No.
Okay.
Nothing was required. We placed both these medial row anchors, passed the fiber tape, fiber wires, and then did a double pulley type of technique, which we will show.
So it's interesting to see you use a tab. Is that your usual practice, or is it because this was a young patient you were dealing with?
Pardon?
You're using a tab before using the anchor.
This was this was a young patient, hard bone. So on the medial side, invariably, I think we have to use it. So we cleared the bed laterally, where we have to place the anchors, and then so that there is a good tendon to bone healing, which we could achieve in this particular case. So after clearing, we did this lateral row repair. As you can see, the tendon could be brought right till the footprint could be completely covered. So that was a good sign where patient came to us early and we could achieve this type of reduction.
So are you concerned about the tightness of the repair, considering that
no, it was completely tension-free repair. We could there was no tension at all. That was our primary concern. So in spite of being a short tendon somehow, and then we retrieve the fiber wires from both the anterior and the posterior anchor and tie the knots outside. This is the, as described by Stephen Beckart, this is a double pulley technique. We pull in these sutures and then use a double pulley. So that's a knot, and then we retrieve the rest of the two fiber wires and then another knot, so that this achieves good amount of compression. Since we had done a good subacromial decompression, we didn't have any concern that these knots will impinge on the acromion, which is one of the cause of the failure of the rotator cuff. So at the end, you can see that we achieved quite a good type of end repair, and so this was the end picture. We repaired the glad lesion also in the same sitting, and so this was the movement at 10 months. Patient had a good range of motion and good functional outcome. So this has been more than 1 year now, and patient is in, so far it's too early, but patient is in doing quite well. So the take home message is that the tears at the musculotendinous junction are quite challenging. We were extremely lucky that we could do a tendon to bone healing and classify them by the presence of whether there has been a previous surgery or this is a primary event, and the tear pattern as has been described, A, B or C. Prevention of medial cuff failure is very important. So to prevent that secondary type of failures, it is very important that the bite that you take through the tendon should be 5 to 7 millimeter lateral to the muscle tendinous junction, so that you achieve the correct length tendon relationship. And then most important, reducibility of the tear and the quality of the tissue determines what are the repair options. Thank you very much for your kind attention.
Thank you so much, sir. So, in case you were not able to reduce it back so nicely, what would have been your next option?
Since I have no experience with either transfers or superior capsular, all I would have done, I would have done a medialization of the footprint and do a repair.
Take out the lateral part of the tendon in that case.
Pardon?
So in case you can't get a full coverage and you can only bring it to the medial aspect of the GT, would you take out the remnant of the tendon, or would you leave the tendon there?
I would leave that because that is not interesting.
It's not coming the way.
In this also we left some tendon. We created a bone bed lateral to the remnant tendon. And over the previous tendon, this repair came. We were very extremely lucky, I think, in this case.
So in the MR, I think we saw that there was a decent amount of stump that was left attached to the GT. So could you have just overlapped it?
So we did an overlap, lateral overlap, but there was no tendon to tendon. We did a tendon to bone. So the medial side overlapped the lateral tendon side, and then we created a bed lateral to that side.
So the stump was taken away?
No, not completely. Just the part lateral to the stump, just to have the space for the lateral row anchors.
Right, okay. Thank you.
Thank you so much, sir. We request